This conference will now be recorded.
Okay.
And by the way, last place, Jake does not have anything to add to the conversation. Thank you
Oh,
for
for
asking.
Christ's sake, I'm so sorry. We always do that. Wait a minute, I read everybody's name and I didn't read your name and you didn't say anything, did you,
I know
Jake?
that. I noticed.
But I left silence and you said nothing. So how am I supposed to know if I don't? How about you? Do you need time?
No, thank you.
Are you sure?
I'm sure.
Because we're never sure with you. You know that.
Well, I'm never
Okay.
sure with me either, but no, I'm okay.
I don't blame you. Okay. So
Rick, this is Jim in Colorado. I just want to ask a very, very quick question. I know you record all this. Is it possible that certain pieces, if I ask, don't record it, it could be non-recorded? And it's just a yes or no. If you can't do it, I understand.
It's not a yes or no answer. I don't know. Jake could tell us. Can we pause and then start it up again, Jake?
Yeah, we can. I think we can pause.
Okay. Then the answer is yes, we can. You just have to let us know when you'd like it paused.
Well, when it comes to me talking, then we'll deal with it.
Okay. Okay. So yes, we can do it quite simply, and Jake can take care of that.
Well, I've never done it before. I think we can do it, Rick.
Okay.
I know there's a pause button, but I don't know if we can. I don't know if we can restart it or not. But we'll try. We'll see.
We'll try. We'll try.
Then put me at the end.
Yeah.
Okay, we'll figure it out. Don't worry. I mean, what's more complicated is if we have to go in and edit it, which can be done, but it's very, very time consuming.
No, I don't want anybody to do that. No.
We can do it, but we try not to do that because it's not easy to do.
No, then let's not do that. If we can't do it easily,
No, we'll try with the pause. We're going to try with the pause. We'll try and see if the pause works. I think it will work. Alexander, let me give you, as you can hear, many of us know each other on this call for a long time. And we're a very friendly bunch, and we're especially friendly to new people coming into the group.
Great.
What we ask you to do, if you would, is to give us a very brief update or summary on your situation, your age, where you live, who's treating you, your disease demographics, where you are in treatment, and if you have any questions, tell us what those questions are, and then we'll briefly go around and get the feedback from both the moderators and anybody else who's on the call. Is that comfortable for you to do?
That sounds fine. And if I forget anything, information you need, then just remind me. And I'll just tell you, I'm calling. I want to get to a specific question I had for the group in terms of people's experience. So rather than asking questions that need a factual answer, it's more about people's actual lived experience.
Excellent, that's fine.
So that's what I want to get to. So anyway, I'm almost in about a month, I'm going to be 78. I live in, I'm also in Marin County, which is where I live, in Fairfax, California.
Okay.
I was first diagnosed in beginning of November of 2000. Didn't have any allopathic treatment at all until December 2016, when after a few months, revealed by MRI originally and another biopsy, seemed appropriate to need to do some primary treatment. And so I had complete prostate removal. And then, so that was December 2016. In June of 2017. No, that's not right. So my PSA never went to 0 after the surgery. It went down to a very small number, though, 0.026, I think, was the lowest it was. And then it started climbing very slowly. And then before I had the surgery, I had, for those of you who are familiar with it, PSMA imaging test, PET, and in that time it was a PET CAT, and that showed, anyway, from the surgery it showed that there was a possibility of having escaped the capsule, but it wasn't clear. I had another PSMA in June of 2018, last year, and that showed 4 spots of metastasis, 3 in bony tissue in different places, and 1 in a lymph node in my upper part of my chest near my clavicle on the left side. In the month of August, I was treated with SBRT, for those of you who are familiar with that, very focused radiation treatment, and just been following my PSA ever since. And for a while, it was stable for a couple of months, and now I've been getting tested monthly, and for the last 3 months, it's been rising. Mm-hmm. And now, I probably compared to some people, it's still on the low side. It's, let's see, what is it now? Hold on. It's now 2.83, which may seem low, but it's rising. And so the question is, what's next? And I haven't, so far, I haven't done any hormone blockade, but that may be coming before too long. What's coming in, trying to remember, I think it's in about just over a week, I'll be getting another PSMA imaging.
Okay.
With a PET MRI. And the oncologist and I will be looking at the results of that and trying to figure out where to go from there.
Okay. Couple of
so
questions.
Anything else? Yeah, I was going to say anything else that you folks need in terms of specifics? Go ahead.
Yeah, let's go back to when you were first diagnosed.
Oh, well, one more thing let me add. So I'm being treated at UCSF, University of California, San Francisco.
Who's your doc?
Pardon me?
Who is your doctor?
Dr. Agarwal, medical oncologist.
Yeah, I know Rahul pretty well for years.
Okay.
And was that who treated you when the disease came back? Was that who you went to immediately, or did you? Well, let me step back one. Who did your radical prostatectomy?
The surgery was Peter Carroll.
Okay, and Peter, who I also know very well, and others on the call do, but we know him really well. He was also Peter Kafka's doc, who's on the call. And so Peter referred you to Rahul, and you started with Rahul in what, around June of 18?
No, it's not that. It wasn't that direct. I actually, before I decided on what to do next, I did meet with Rahul once, but that's because the other medical oncologist that I had seen once, was very experienced, suddenly left for another institution in a different part of the country, and so that's how I ended up meeting Rahul. But I didn't know I'd be working with him regularly then, and meanwhile, I also started consulting with an oncologist in Marin. So that's that background, and his name is Alex Metzger.
Yeah, I know.
Metzger. Okay.
Marin General, right?
Well,
So-
yeah, it's Marin Cancer Institute. And do you
Yeah,
want to know who
yeah.
did the radiation treatment?
Right. And was that Chuck? Were you with Chuck? And then you moved over and Chuck left and you went over to Rahul?
No, I don't know who Chuck is.
Charles Ryan.
I guess, yeah, I never knew him as Chuck, but anyway, I only met him once. And
Yeah.
I liked him, but I didn't have much time with him. I was mostly with kind of a resident. So anyway, I was disappointed. But anyway, I'm very happy with Dr. Agarwal at this point.
Yeah.
Do you want to know who did the radiation treatment?
Yeah, who was it?
I have to remember his name. He also in Marin, and I have to.
Oh yeah, I know. I think I know who did it. If it was in Marin,
Japanese American, and I can't remember his name right this second. I'm very fond of him, and I think
Chinese.
Anything else?
Asian guy, right?
Yes, correct.
Yeah, I know.
Yes.
It'll come back to me. He's very experienced. He's very good.
Right.
Okay, so let's. I think we have a lot of information. I think the thing that surprises me the most is I'm just surprised Rahul has held off the hormone therapy, which would definitely be the first step. I think if it were me, we know that the earlier the intervention, the better. And there's a lot of research.
Well, on the other, I understand that. I understand that. I appreciate Rick the advice, but anyway, I have a specific question. Let me just say that I've also made clear to my doctors that all things being equal, I'm concerned with quality of life issues,
Right.
and so I'd rather, I would want to have a very strong reason to begin the hormone treatment sooner rather than later. I don't want to be imprudent in waiting too long. But anyway, so I think my doctors have that in mind, and I don't feel like they're, what Dr. Agarwal said to me last 2 or 3 weeks ago was that, and the other oncologists concurred, is that with my PSA, the low numbers, PSA may not be the whole story as to what's going on, and so that's why they recommended another PSMA. And fortunately, its availability in San Francisco had been halted for a few months, but it's reopened. So
Right. We're aware of
I'm happy to be doing that coming up. Yeah.
Right.
So that's where that is.
A couple of other questions I was going to ask you. Now, let me defer. What is your main question for us?
Thank you. That's what I'd like to get to. I'm guessing that perhaps many of you or most of you have done hormone treatment, perhaps are doing some form of hormone treatment at this point, or are beyond. Maybe you're, you found that you're castration resistant at this point, whatever. My question is, are there some of you who have been doing both Lupron and Zytiga? And if so, along with the prednisone, of course, and if so, for what length of time? And then the second part of that question is, if you have you been doing the Zytiga at the full dosage on an empty stomach, or any of you experienced doing the Zytiga at a quarter dosage with a meal with fat in your breakfast? So those couple specific questions, I'd like to hear about people's actual experience, and then what has been your experience?
I can answer that.
Jim, hold on. No, I'll come to you. I know there's a lot of people that have this experience, but I will definitely get back to you. When in the 618, when the PSMA showed Mets in the lymph near the clavicle, you also mentioned it showed Mets, tissue Mets. Where were those tissue Mets?
I said bone. Is that what you mean by tissue?
Oh, bone. Okay, then I missed that.
Three to bone and 1 to lymph node.
Okay, 3 to bone. And where
Yes,
bone?
and so the one near the clavicle was in a lymph node.
Okay, and bone. Where was the bone?
Oh, I have to remember now. One was on the one side of my sacrum, and I don't remember where the other two were.
Okay,
I would have to look.
Worries. No, I mean that's really, it's important. I wanted to make sure. I just wanted to come back because I thought I'd heard tissue, and
they were all quite small, right. And so I think they were happy because evidently some people, PSMA doesn't show up very well, especially at a relatively low PSA level.
Right.
So the fact that I did get a response both the first time I had it and then again this time, it's helpful. Of course, I'm never thrilled about the extra radiation, but for the test. But anyway,
right.
So that's where I am with that.
Let me go. I mean, I can see immediately at least 4 people here that can answer your question.
Great.
I think I'm going to, and I'll get to all of you. I just ask you to be concise because we've got 9 people that want to come back on this call. So I'd like to spend no more than another 10 minutes if that's possible, or 15 minutes at the most. Let me start with Dennis Correa, because I think you've probably been the longest on this call on Lupron and Zytiga plus prednisone. How long have you been doing Zytiga and Lupron, Dennis?
Yeah, I started Lupron in 2016, and then less than a year after that, I believe they added the Zytiga because the PSA had started to go back again. But a little different story than you. I did not have a prostatectomy, but my original diagnosis, I had, I think it was 5 bone mets, and primarily in the spine, and also lymph node involvement. So I think that could be a little bit different than what you had, but I'm 74, and it's a tough deal to number one, accept that I had this disease, but I started right away with chemo because I was still metastatic, and Lupron or Firmagon. I started with Firmagon, so I didn't get the flare up at the beginning, and then switched over to the Lupron. And yes, you do have the hot flashes, and it does give you some fatigue. You feel older than what you are. A lot of it's going to depend on your own physical condition to begin with.
I'm sorry. Could you repeat the last sentence, Dennis? I missed it.
Yeah, a lot of this is going to depend upon what physical condition you are in to begin with before you start this stuff.
Right.
And this time to time, it's there's some emotional issues with this type of treatment. There's also the hot flashes, and obviously it's an end to your sexual life. But I continue to do a lot of. I play 2 18-hole golf tournaments a week, so.
And has your PSA dropped to 0 or close to it?
Yes. In fact, I was going to say, just got my recent result here. I get tested every 3 months for that, and I'm down at less than 0.1.
Oh, terrific! That's great. Is your doctor suggesting that you stay on it continuously as long as that is the case, or are you talking about possibility of experimenting with intermittent?
No, not at my point here. There are people on the call that have done that, but mine is I'm on it for life. And the issue about the reduced dose, I discussed that. I have 2 different oncologists. I have one close to me in Tucson that I go to every 3 months for the routine blood stuff, and then I go up to Mayo to see my primary guy. So while I was there, the issue of the reduced dose possibility came up using a quarter of the dose on I believe it's a low-fat diet, low-fat meal rather.
Well,
and
a meal with fat, and
with fat.
not necessarily low. Yeah, with fat. It has to be with fat.
Yeah, but I could never find
it's fat soluble.
Yeah. Okay. I never found a good definition of what that meant. And because there's so much variability in what that meal could be among different people, my local guy here, while I was there, he actually texted my other aunt back up in Mayo, and he was opposed to it. For me, he said, no, we should, continue. It could have some benefits for people for whatever reason, from a cost standpoint, from a tolerance standpoint, it could be useful. But for me, for my situation and how I'm doing on it, he recommended not changing anything. So I do that with the prednisone, 5 milligrams a day on the prednisone.
And one more question for you, Dennis. I understand that you're getting much better control with both medications. Have the side effects, you noticed them being more severe when you started adding the Zytiga than just when you were taking the Lupron alone?
I wouldn't go to the point of being that much more severe, but yes, they were more. Some of the things were more frequent. Some, like the emotional issues, have decreased, almost non-existent. The brain fog is about the same. The fatigue issue is probably about the same. The hot flashes is probably about maybe a little less. So.
And if you're planning to stay on it long term, that's necessary for you. Are you at all concerned about some of the other possible longer term effects? Osteoporosis, et cetera. And your doctor monitoring all those things for you?
Oh yeah, yep, yeah. I do a bone density test every 2 years since I did a baseline when I was diagnosed, and we're not seeing. I'm not whatever they call it here.
Osteopenic.
Yeah.
Osteopenic.
I'm not at that point yet. So I do a lot of calcium, vitamin D3.
Yeah.
And I have not needed.
Thank you very much.
I'm going to jump in.
Thank you very much. I really appreciate it. Really appreciated that feedback.
Alexander, hold on a minute, because we got so many guys. I'm going to ask Peter, because Peter not only has your doctor and knows the players we're all talking about, but Peter's also done and doing intermittent. Peter, and he had an RP. Peter, do you want to chat a little with Alexander?
Sure. Alexander, did you say what your Gleason score was? Might have missed it.
Oh, gosh. Hard to remember, I think. By the time I actually had, the surgery rather than pre-biopsies. Originally, it was when I was first diagnosed, it was 3+3, and at the time of the surgery, it might have been 3+4 or something like that.
Okay,
but it was never at the 5 stage.
Good for you. Good for you. I'm a 4+5, a 9. I had surgery with Dr. Peter Carroll back in 2015. I had follow-up radiation 2 years later, and I also had a gallium-68 PSMA PET CT in San Francisco as well, because I had some movement and I knew something was going on. I had very low PSA. I've been on intermittent.
I'm losing you a little bit, maybe if you're on a cell phone or something. But anyway, when did you have the PSMA? How long ago was that?
Earlier, a year ago, 2018. And I've been on intermittent status ADT for the last 5 years, on and off. Almost all of 2018, I was on Zytiga for the first time. I went off on New Year's Eve, so I've been off for about 9 months now. Been fine. My testosterone's back again. The Zytiga wasn't a terrible ride for me. I've been kind of used to the Lupron and so forth. I myself never got hot flashes. I do find brain fog, so forth.
Sure.
One big difference with me is Peter Carroll suggested I do SBRT because they did find a couple of metastatic lymph nodes in my abdominal area. I chose to go down south to San Diego and have proton beam radiation with Dr. Carl Roth. And that seemed to have zapped it really well. No side effects to that radiation at all. It was quick and smooth. Go back to my oncologist on Thursday morning. I'll do another blood test. And so far, I seem to be doing fine. I don't have any big issues, and I'm keeping my fingers crossed that everything stays fine. So
Peter,
I hope so.
Peter,
And you're being monitored at this point strictly with PSA?
Hold on a minute, Alexander. Peter, I have a question for you. What was the difference for you after being on the ADT for a year or so, or a little longer even, and then adding the Zytiga to that? What was the experience? Did you feel weaker? Talk about that a little bit.
I was surprised that I had hardly any physical reaction to the Zytiga. I took a full dose without food every morning, 1,000 milligrams, and I had no problem with it. The only thing I do notice and have noticed with the Zytiga and since is increased brain memory loss type of stuff. And I can, I'm 72, you know, I could make believe it's age, but I don't think so. I think the Zytiga did a number on my head. Terrible, I can live with it, but things that I know I should remember, names, this, that I had well in place before the Zytiga are much more difficult to bring up now. That's my only problem. But I'm
Alexander.
How old are you? Peter, how old are you?
72.
72.
Okay.
Alexander, we will connect you to any of these guys, and they'd all, I'm speaking for them, but I know them well enough that everybody would be happy to talk to you later. I just want to get around a couple of the others because before.
No, I think I would like to do that. I don't want to monopolize all the time, but even just hearing from a couple of people has been helpful, and I'd be happy. Let me just say, Rick, that I'd be happy to be able to connect with any of you folks at another time. It doesn't have to be, in the weekly overall call.
Okay, so we'll talk about that before we leave you as to how we're going to achieve that. I'd like Jim in Colorado. Have you been? You're on both LHRH and
Zytiga and prednisone.
Right.
And I'm on like 4 other things. So, but the main thing is Lupron and Zytiga. And you do get brain fog. And I know it's incredibly difficult because you don't realize that it comes on. And you don't realize how bad it is. And it's a surprise that it happens because at least my oncologist did not tell me that it was these were the side effects. And all I got to say, Raul, I'm sorry, I'm terrible with names, but you forget things that you go into a room and you forget stuff. It does affect you that way. And you can mitigate the problems, but it's still there. And it just doesn't, learning how to live with it is 90% of the battle.
Okay.
And it's not easy. And if I'm sure Rick will give you my number. And if you ever want to, discuss what it does to you, because I can't drive, not because I can't drive, because I I'm not comfortable that it's safe for anybody else on the road, that my, things happen. And you gotta change your lifestyle to adjust to having this medication. And I don't know, it's not everybody. I got a good friend of mine who's on it, and he does great. He has no problems. So it's not, everybody doesn't react the same way.
Right. My experience with the doctors, they tend to say, from my limited exposure, they tend to say, a lot of people do really well with these things, and that may be the case, but they may be more reticent to talk about what are the possibilities if you don't do really well. Not if you're the 1/100th of 1%, but just what to anticipate. And so anyway, that's why I've been a little cautious. At the same time that I'm sort of preparing myself, and my experience will be my experience.
All different.
But
you don't. The problem is you don't know.
Right.
You don't know
that's why it's
until you've been through it. I've been through it for almost 2 years.
That's why it's helpful for me to talk to a few of you who have been going through it, and each of you has your own experience. So I appreciate that.
So let me jump in here. Has Agarwal given you the hormone therapy pamphlet, UCSF hormone therapy pamphlet?
Are you talking to me?
Yes.
Alexander? No,
yes.
I haven't gotten a pamphlet, but I've read so much stuff online, and
okay.
when
let me stop you. There's a lot of stuff online. Go to.
Yeah. Well, anyway, let's find. Go ahead.
Hold on. Go to our resources, or I will send you the link. We wrote an excellent hormone therapy pamphlet published by UCSF, which is read now across the bloody world. And
great.
It's a very good document for you to read. And I'm sad that the UCSF oncologists are not giving it to all their patients, because that was the deal.
Well, you know what? It probably hasn't been considered the appropriate time yet. So anyway, he probably will anyway. But if you'd like to send me a link, that
we will send it
by
to
email,
you.
that would be appreciated. Thank you.
Right now, Len, before we move on, I want to bring you into this conversation because you may have some thoughts.
Well, as you know, Rick, I'm only on Zytiga a few days now, so I probably don't have anything to add to the guys who've had much more experience. I can tell Alexander that just on the spur of the moment, after I got the script, I just decided I was going to try taking 1 pill a day with a fatty meal for breakfast, almond butter, which I always have anyway. And we'll see what happens. It'll take a month or two to see what happens. But other than that, I have nothing to add to it.
That sounds like heaven.
How will you monitor how well it's working?
PSA decline, I suppose.
Okay, but I mean, how would you compare that with how you would do if you took a whole pill on an empty stomach? Sounds like there's no easy way to tell.
No, there really isn't.
Okay.
So let's just get to the brass tacks. Alexander, we don't have your email, but let me tell you, if you would like to email me, my email address is rd, Richard Davis, at ANCAN, that's Alpha Nancy Charlie Alpha Nancy, ancan.org. And what I will do... Sorry, Ken?
Just wanted to make sure you told Alexander what Lynn's background is.
What Len's background is?
Yeah.
Sure. So Len has long experience in intermittent. He's been very successful on it. Intermittent. He did Zytiga 2 years ago or so for 3 months, and then came off. Len and Len is a research pharmacologist, retired. Len, and he's also my very, very capable co-moderator. Len, anything you want to add?
No, I think you covered the background pretty good. That's my whole life right there.
Well, you know what? I would appreciate, again, being able to check in directly with some of you guys at some future date as things evolve for me, without necessarily having to involve everyone on these calls. And also, I'm ready to have the group move on. There are others of you who would like to speak today, and why don't we just, move on from me at this point. Thank you all for your attention.
Thank you. Just send
Rick,
me an email.
you have my permission to give him my email or whatever, and I think he may help me. I may help him. Who knows?
Okay, so Alexander, please.
That's always the case, isn't it?
Yep.
Hey, let me join me with that email. Hey, excuse me, Jim from Maui. Make me as part of that email. I want that info too.
Okay, so there are guys that would still like to speak to you. So be sure to, or if you're comfortable, you can give me your email right now.
Jim,
I'd be happy to do that.
No, Alexander.
No, I'll give it to you right now. It's abinnick, abinnick@comcast.net. I'll spell that.
Yeah.
A, B as in boy, I, N as in Nancy, I-K, ABINIK, Comcast.net.
Got it. So what we'll do is we'll put you'll receive a note. How did you hear about us, Alexander?
I think I found this group, do some online sleuthing a number of months ago, and Rick, you helped connected me up with for the calls, and it's just never been the right time for me. This is often a time day out here when I need my nap. So anyway, finally, today was going to be the day.
Fantastic. And you can tell Rahul when you see him that I said hello. And that's it. Okay, we're gonna move on. And
thank you all.
It's a pleasure. Jim Ward, are you still with us?
Yes, I am.
Take the floor.
Okay. Well, I'll keep it brief. I know we have a lot of guys who want to ask questions. I just want to say I'm coming up tomorrow is basically right on the cusp of halfway through my radiation treatment.
I love you. I love you.
Did you guys hear me? This sounds like there's some background noise.
Yeah, go ahead.
Anyway, coming up on the halfway point, treatment's treating me fine so far. The only thing I've had some experience with is a little bit of burning urination, and then at night it just seems like I'm having to get up 3 and 4 times, and while I feel like I have to urinate, but then it's it's not like it's hard, start, stop, weak stream, whatever. I know they warned me that could be the kind of side effect, but I guess my question is sort of looking ahead. For those who have been through this, if you experienced that kind of side effect, is that something that hopefully, something that kind of leveled off or stopped sometime after your treatments? Just curious if anybody's been in that boat.
Who would like to answer?
I would.
Okay.
I know, Rick, that you don't like when I answer, but the reality is I was getting up 12 times a night, and hot flashes. And I know nobody wants to hear this, and this is not, normal shit, but I did CBD. I get up 4 times a night, and I'm sorry, don't expect that you're going to get up once a night anymore for the rest of your life. it is not going to happen. But 4 times as opposed to 12, I love it.
Okay, let me stop you there, and just because I just wanted that question, we're happy to have your contribution, Jim. Did you do radiation therapy?
No, I haven't done radiation.
Okay, so let's just.
I'm beyond that.
Right. So let's just hold the conversation to radiation therapy for the time being. We have a lot of people on there. We can certainly discuss that, or you can discuss it. But what we're asking is, who has done radiation therapy? There's a bunch of you on the call. You've done it. Have you had an issue with urination?
Rick, go for it.
This is Jim. This is Peter. The burning will go away. Not only in my experience, but everybody I've talked to that had that symptom, it does go away, and the frequency of urination will go down too. It's just part of the ride with radiation. It just happens.
All right.
Anyone
I'm
else?
assuming you're talking about. I'm assuming you're talking about radiation to the pelvis. Pelvis
Yes.
Cavity. Okay.
To the pelvic girdle.
Okay.
Ken Anderson.
That's correct. Yeah.
Ken Anderson.
Yeah. Hey, Jim. I can second.
Hey, Ken.
Yeah. Halfway through, I noticed. I went through exactly the same thing. I noticed, and I must admit, I was getting up more frequently than 3 or 4 times a night. And it must be something with the radiation around the prostate gland that causes, it goes right through it. It causes the need, at least the sensation for the need to go urinate at night. But
yes,
it does go away, and it'll get much easier. Like last night, I didn't get up once. So with time.
Oh man, what a dream!
Oh God, that is amazing.
You'll find.
Well, I'm glad to hear that, Ken, and Peter. Thanks as well for just kind of verifying that you and others anecdotally that it does kind of ebb off. And I can't cite any other significant side effects from the treatment. So I should count myself.
Congratulations.
Len, how was your experience from your radiation?
I had, as far as acute toxicity goes, I had nothing. 15 months down the line, I had radiation proctitis. But Jim Ward, did you have, in addition to the IMRT, did you have brachytherapy?
No.
Oh, so you just had IMRT. Same thing I had. Yeah, I guess maybe I was fortunate. I never had any urinary burning or urgency or frequency or anything like that. But everybody's different. And as Peter said, no doubt it will mitigate and disappear over time. The bladder is right next to the prostate. So while they're radiating there, the bladder is going to get irritated. That's probably what's going on there. I wouldn't worry about it.
Okay. Well, thanks, guys.
Anybody else before we leave?
Yeah, I have a comment. Paul Frieda here. Before my prostate turned cancerous, I had a very large prostate, BPH, and I would have to get up 6-7 times a night to go to the bathroom. And what I did is I cut off a 2-liter water bottle and kept it by the bed. And every time I had to urinate, I just leaned over and stuck it in there, and then I never had to get out of bed. I just could immediately relieve myself.
Wow. Okay, I may consider that.
It worked very well for me for several years.
Yeah, I may consider that. That's not a bad idea. Thank you.
Anyone else before we leave? Okay. I just
Can I say one last thing? One last thing, Rick? I want to thank this group, and particularly those who know who you are, who nudged me to go down to MD Anderson. I think it was a great decision.
Fantastic. We're so pleased. Yeah, I mean, it's so great to hear that you're so more comfortable now than when you first came on this call, and assured, and that to me and to Ken Anderson and others is very, very gratifying. and so we're thrilled about that. I just want to say to you, in my own experience, I didn't have a lot of burning during. I had an urgency. That was the issue. It was more urgency. It all resolved, but it did come back. And probably for on and off for about 3 years, I had issues with urgency at night, during the day. But now, the last 2 or 3 years, it's been just fine. So everybody's different. So we wish you lots of luck. And I'm very excited for you actually meeting Ken in person later this month. I wish I could be with you when that happens. So
yeah, excited here as well. So thank you.
Okay. And everybody on the call should know, and we are thrilled that Ken has agreed to join our board of directors. It's very exciting for us because I think that, we've always felt, or I've always felt, Ken has tremendous experience, but he had a business to run until recently. And we're really, really excited, Ken, the prospect of working with you. It's terrific, and thank you for agreeing. Okay.
Hey, Rick, thanks for accommodating me on the call. I do have to jump off. Take care, everybody.
Absolutely. Okay.
Take care.
Let's go to Al Fat because we love your story and we'd like to get an update on it.
Okay, well, the Erleada trial is over. I got a year out of it, and I don't know if I got ambitious or what, but just to fill you in, I was taking it as a monotherapy after the Firmagon before I became castrate resistant, but when the T levels leveled off and the PSA wasn't going down, I thought that was time to jump ship, and I didn't want to have the dual side effects of the two medications. So for the last year, up until last month, I had been taking Erleada by itself, and I had a really good run with it. My PSA got as low from 5 down to 0.05. And then about 5 months ago, I guess it was, no, it was 8 months ago. So like around December when I was going on vacation, I wanted to see if I could get by with a lower dose because I was having a lot of joint pain and what I call motor neuropathy, real heavy feet, and I just wondered, whether since I had taken the Prevenge treatment earlier, that might be enough to let me get by with a lower dose. So after about 2 months, it was clear that wasn't the case, and my PSA started to increase again, like it does exponentially when my treatments aren't working. I was having a doubling time of about every 2 months or so. So we went back up to the full dose, and it bent the curve a little bit, but didn't level it off. So I said, okay, it's time now. And I took I was going to take a month off, and then just let my body get back to where it was. But at that time, my PSA was around 0.14 or so. And I thought, I have a little room to play. Let me just, chill out for a while. I have a very aggressive cancer, but, in imaging studies, it's like the first speaker. I've got like 3 small bone nets and lymph node involvement, but over the 5 years that I've been kicking this thing around, it's, pretty manageable, actually. I think anyway. I feel pretty good. But my doctor said, this is Dr. Olin, that he wanted to see whether I'd be eligible for a trial with darolutamide. And I said, well, okay, sure. But, it's okay. Let's see if I can. And it turns out the insurance company approved it. So rather than take a month off, I just said, okay, I'll start right away then. So 2 weeks after I stopped taking anything, I had my PSA, and it was shooting up the fastest it's ever increased. You know, it's more than doubled in 2 weeks. So I'm glad I didn't take that time off. So I've been on the darolutamide now for about 3 weeks as a monotherapy. I'm going to see Dr. O, my oncologist, in about 2 weeks or so, and we'll see what's going on with that. The really great thing, though, about while I was taking the Erleada as a monotherapy, my mind, I wrote like 3 articles. You know, I was really very, very mentally alert, and didn't have that fog that I had when I was taking the Firmagon. So I was really glad to have that period where I could finish up a number of the things that I had been working on, sometimes 3 years, you know, before I wasn't able to complete them. But we'll see what happens now with the I feel really good, you know. I mean, I have a lot of joint soreness. I have osteoarthritis, and you know, I've got bone mets, and I've got treatment side effects. So, you know, all in all, I'm getting around okay. And if I had to spend the rest of my life like this, I'd be fine. So that's me.
Al, can you fill us in a little bit on the PSA? You mentioned it was moving up quickly. Well, I mean, what was it when you stopped your Erleada monotherapy?
You know, it had gotten up to 0.05, and I was headed down. Maybe it was going to be undetectable. I don't know, but it was going down, and that's when I decided I was going to see if I could have a, you know, if it would stay low with half a dose. And
right.
The following month it was 0.6, the following month it was 0.7, and then it started going up again, you know, exponentially like it does when it increases. So it got up to the last study was 0.42, but that was after 2 weeks of not having any treatment. It had been I think 0.17 before that. So it's still, you know, it's low, but it's rising quickly, and I didn't want to let it run like that. So I decided to start the darolutamide sooner than I had anticipated. I was going to take about a month off, just to, you know, kind of, you know. And I was also considering that I might do the medical marijuana again, but I thought better of that. I think that was a good time to do that. I'm going over, by the way, there's a international conference in London. I submitted an abstract for that. I haven't heard whether it's been accepted or not, but I'm hoping it will be, and I want to go over there and hear what the Israelis have been up to, because the last study they published was just incredible in terms of what they've been doing with the you know, the basic science research of the medical marijuana, but they don't have any clinical data to present, and I've got at least a little bit.
Let me just stop you, because we've got to sort of move through more quickly than I would like to. But when you started the darolutamide, what was your baseline PSA that we can see how effective the darolutamide is? Was it 0.42?
0.42.
Okay. And have you done any scans? Has Dr. O scanned you at all recently?
It's been a while. We talked about that. You know, it's a question, what would we do with the information? You know, so I think I'll probably wait for a while. If the darolutamide works like the Erleada did, then I don't think I'll bother with a scan for a while. You know, I had a bone scan after a fall, and it picked up, you know, a point to compare with the bone scan I had a while back, and it doesn't seem like the bone nets are doing very much, you know.
Good.
They're just there.
Len, I'm sure you have some questions.
I sure do. Yeah, I'm really intrigued that Dr. O was able to get the darolutamide for you. I would love to have gone on to darolutamide, but I actually called their they had some kind of free access program for 2 months, free darolutamide, and they told me that because I was metastatic, I wouldn't qualify. You have to be non-metastatic, at least according to the FDA approval. So I was wondering, did Dr. O talk to you about that, saying, well, I can get you in anyway, or how did that conversation go?
I fall between the cracks, you know. It's not like you have to be metastatic. You know, the whole thing with FDA approval is that you can use off-labeled indications if there's a clinical, you know, rationale for it. I worked with psychopharmacology and psychiatrists back in my professional career, and everybody gets all hung up about, oh, it's FDA approved, it's not FDA approved. You know, all that is just for the insurance companies to decide whether or not they're going to pay, basically. There's a clinical rationale, and I think his rationale was that since I responded and then stopped responding to the Erleada, that it was worth a trial to see if this would work. I don't know how he does it, but he did it. And the insurance company, I've got Medicare just like everybody else, everybody else my age, and they approved it.
What's your copay, if you don't mind me asking?
I don't have any copay.
Oh, good. All right, I'm
yeah,
gonna
give
Dr. O a call probably tomorrow.
I'm his canary, I think. You know, he lets me, he gives me a leash, you know, and I kind of listen when he says that's not a good idea, but he lets me, you know, sort of play around. I've got a very quick detection system to be able to tell when things are going south or if they're working well, and he's given me, you know, it's been a really great relationship. I really like our working relationship, so I appreciate that a lot about him.
Yeah, he tells me, he says, I'm very flexible on the things that aren't really important, but if it's really important, I'm not flexible.
Exactly. That's what I experience as well.
I agree with you. Well, please come back on and let us know how you're doing on darolutamide.
I'll do that.
For those of you who are not familiar with darolutamide, Nubeqa, I think, is what it's the name. It was recently improved. The big advantage of darolutamide, and Len has been kind enough to post some information on this on our blog. If you're not signed up to our blog, we strongly recommend you do sign up. Is that it supposedly doesn't cross the brain barrier. Now you may say, what's the brain barrier got to do with the price of bananas? Well, we have androgen receptors in our brain. And so when you take these medications, they can impact your brain because they don't know where the androgen receptors are. They're just attracted to androgen receptors. So when you have a side effect that is affecting your cognition, your fatigue, it may well be that it comes as a result of the medication impacting the androgen receptors in your brain. The selling point of the darolutamide is that somehow they've designed a drug, I don't know how they did it, Len may know, that doesn't cross the brain barrier. So it becomes very interesting to people that are on androgen receptor drugs. And so that, in a nutshell, is why darolutamide is attractive.
Mm-hmm. I'll tell you one other thing, Rick, and then I'll just pass on here. When I was taking the Erleada by itself, and somebody from who's the country, Johnson & Johnson, that makes Lupron?
Yeah, Janssen. No, not Lupron. AbbVie.
Who makes Lupron? Anyway, Joel was talking to the drug rep, and he was, because a lot of people are following this story. And he said, wow, his nipples must be really sensitive and his breasts must be really enlarged. So apparently, when you take Erleada by itself without having the other medication, that happened. So I wasn't aware of that, but apparently that's a reported side effect, that Erleada by itself leads to very, tender nipples and very, firm breast. The gynecomastia is heavier. That's abated considerably since I've been taking the darolutamide. And I asked the pharmacist about that, and he said that'll probably happen. Probably won't be as sensitive to that.
I'm not sure why.
What that?
Len, do you know why that would be?
I was having a little trouble hearing him there. Was he saying that there's less effect on breast tissue with the darolutamide?
Yes.
That's what he was saying, yes. I would experience less effect, and it's true, I have.
Okay, so first I'm hearing of this, so I don't really know what might be responsible, but whereas Erleada and enzalutamide are very similar chemically, darolutamide is different chemically, and so maybe it somehow just doesn't affect breast tissue. I really don't know. I'd be interested in looking that up. That's a double bonus. You don't have the cognitive deficit, and you don't have the concerns about breast tissue.
Yeah. And do you know why it is that the Lupron attenuates that effect when you take it with the Erleada? Because I heard indirectly through Joel Nowak, who talked to a representative from the Lupron company, that would be expected, and I didn't know that.
Yeah,
apparently that's a positive side effect of the interaction.
Yeah, that's because Lupron keeps your testosterone low, but if you're not taking Lupron and you're just taking Erleada, what happens is a certain amount of testosterone, which you have quite a bit of on Erleada, gets converted to estrogen. So the estrogen is feeding the breast tissue.
That's what happened. Yeah.
Basically, unopposed estrogen at the breast tissue.
Right.
Yeah. And the other thing that happened when I stopped taking the Erleada was, in addition to my PSA going up, my testosterone level came down considerably.
Say that again, please.
The Erleada was bringing it up. My testosterone level doubled from my previous values before I had cancer while I was taking the Erleada. It didn't just release the normal level of testosterone that I had. It actually boosted it to about twice the value of my normal level.
Okay.
Well, so the problem with testosterone is it is terribly, terribly erratic. You can measure it one day and it can be 900. You can measure it the next day and it could be 600. And Len will attest to that.
True.
Well, these were pretty consistent, Rick, across, they were all about the same. I mean, I had a jump of, 30, points, but this is 150. Well, so we'll see. It's possible. Yeah. Okay. I got you.
Well, it's hugely erratic. The other thing I wanted to mention to you is that when you're taking the LHRH drug, like Lupron, it's also going to stop your production of estrogen as well as testosterone. So when you're on that drug, you have less estrogen in your body. Some of these other drugs, as Len mentioned, will increase the amount of estrogen, and so that probably explains that. So anybody else want to ask any questions to Al before we move on? Anyone? No?
Okay.
Okay, well that's great. Thank you so much for that update. What I'm so pleased about is that you're finding another drug to follow on with so that we can continue this incredible monotherapy story where you're doing well and you're not on an LHRH drug, because there are so many people on this call who would much rather avoid, whatever you want to say, the RH treatment, and so you are a terrific guinea pig, and you're a instigator to get Len working hard with his doctor to get to the bottom of these treatments. Okay. All right.
See you sometime in New York, Len.
Yeah. Okay.
Okay, we're going to go to Jim Kubat, and then we're going to go to Carl Foreman. Jim Kubat, I always manage to lose you and forget about you, and then you leave us, and I don't want to do that this time, so you're up.
Okay, so thanks. I have two quick questions. The first is, can anybody out there who's had any experience with joint and muscle pain and soreness after hormone and/or radiation treatment talk about that? What is it like? How long does it last? Does it go away? The second question I have is, does anybody have any opinions about fasting? I've recently, just today, been reading something about time restricted fasting and alternate day fasting, which is discussed on a website by a researcher down in the San Diego area named Rhonda Patrick. And a coworker of mine who's a cell biologist, he and I are starting to talk about fasting. And I never really was a big fan of fasting until I'm finding out that it has a great deal to do with the circadian clock and metabolism and cell metabolism and that sort of thing. And there are links that I've just briefly read about disease prevention and connections with cancer and so on. So muscle soreness, joint soreness and pain, and then fasting. Any opinions or thoughts, Rick or Len or anybody?
Who would like to kick off?
So I don't know anything about the intermittent fasting, or it goes by several names, but were you asking about hot flashes related to radiation or ADT?
No, not hot flashes. I've had them, although they're starting to reduce in number. But about 2 months ago, I had very, very sudden joint and muscle soreness. So just a speck of history. As of Memorial Day weekend, I was fine. And all through the winter, through my radiation treatment, I had been weight training and doing cardio in the gym. And then, as I usually do, I switch from the gym indoors and I go outdoors on my bike. So the problem with the bike is that it's not weight training at all. And I don't know if that had anything to do with it, but I had an onset of severe muscle soreness in both my Achilles tendons. I would get up in the middle of the night, could barely walk to the bathroom. My Achilles tendons were sore. My right arm, my shoulders, my left arm too, but my right arm was worse. The interior of the elbow was extremely sore, and still is sore, but not as bad as it was. I woke up one morning and I had such a pain in the knuckle of my ring finger, I could not open and close the finger. The joint was locking and then it would like pop open. Even now, it gets better during the day, but stiffens up at night. Both of my thumbs now are very sore and tight, and just the bone, the knuckle, very painful. And it was a very sudden change. It wasn't like, I know I'm getting older, but I think that this was a direct result somehow of the hormone treatment. I was on Erleada. I see that a side effect is joint and muscle pain. But since this was so sudden and none of my doctors mentioned anything about it as I was going through my treatments, I'm just wondering if anyone has any experience with that.
I could join a little bit. This is Jim from Maui. And I want to back up with the fasting too, but I had Neulestis shots after the chemo, and that really gave me joint pains. And that didn't go away for a while. But I did do intermittent fasting and it's called a mimic fasting for 4 or 5 days, where you basically are vegan or very little bit, eat very little, low calorie. And that did help quite a bit, actually, for the joint pain. So you might want to continue with that fasting or go into it and find out which way, the fasting you do works. I know that I was fasting, and then my previous triglycerides weren't that high, but this last PSA and blood test, my triglycerides did go up. I've been doing Zytiga, but I didn't fast in the last 3 weeks. So I think the fasting will help with the triglyceride count also.
Thanks. Thank you, Jim. I want to add one thing about this joint pain and these knuckle issues, because I personally have a lot of that. It does date back to when I was on LHRH. It got a lot worse. I don't know whether that's just a correlation. The one thing I can tell you is that opening your knuckles gets easier and easier. I mean, my knuckles now lock all the time, every day, usually in the morning, but it can be in the afternoon. And sometimes it's really difficult. I can pick up a cup and I lock my knuckles, and I have to put the cup down and get my finger out. I mean, it just causes issues. But the pain from freeing up the knuckles gets less and less. Now, I don't know if that's because I'm just used to it. I know how to deal with it. But I remember the first time it happened, which was before I went on hormone therapy. I went to the doctor and he wanted to give me, or he did give me a shot. Now I just open it up. And so that I can say. The other thing is the soreness. I still, I do think that switching from indoor exercise to the road on your bike is always going to make a difference. And so how much of that is attributable to the hormone therapy? How much of it is attributable to aging body?
Starbucks.
So guys, if you're not talking, it would be great if you could just mute your the computer or the phone, so we don't get your background conversation. Stretching is really helpful. Stretching immediately when you get off your bike is a pain in the butt. You don't feel like doing it, but I can tell you it does work. Who else? And let me just say one other thing on the fasting. I'm trying to find an article for you about fasting and chemotherapy, which was from The Economist. It's a really good article. The person who knows a huge amount about this is Professor Bill, because he's actually studied it. And there is a lot of evidence to suggest that chemotherapy is much more effective after you fast. I don't know if it's true or not, but there is. There is evidence, and when I say I don't know it's true, the clinical trials suggest that. We haven't necessarily found anybody where it's had an impact. Bill did try it in the last few months before he went into hospice. He tried fasting before chemotherapy doses. He feels it made a difference. In your situation where you're not doing chemo, you're just on your drugs, I don't know. But, my feeling is if it were me and I wanted to try it, I'd say, I'd try it. It can't really hurt you and see if you get a result. Who else would like to contribute on this issue, either muscle pain or fasting?
This is Peter. I'd like to say something very quickly. Last year I started getting pretty severe muscle pain on my IT bands, on my legs. This is on my right side. It was before I broke my femur on my left side. Now I've got it on both sides. And I'm going to see a doctor next week, or week after next, for for a consultation about therapeutic ultrasound. I was wondering if anybody else, in lieu of cortisone shots. Wonder if anybody else has done this or heard about it or had any feedback about therapeutic ultrasound.
Anybody know anything about therapy? I mean, I've heard of it, but I haven't experienced it. Don't know anybody. Anybody know anything about therapeutic ultrasound?
Well, I guess I'll let weeks.
Jim.
What I know.
Sorry, go ahead, please.
Yeah, I'll let you know in a couple of weeks what I find out about it.
Okay. Jim Cubat, I just posted the Economist reference in the chat window.
Great.
So you can look up that article.
Okay, thanks very much.
Anybody else before we leave, Jim? Okay.
Okay, thank you.
So Carl Foreman.
Hello. I was going to contribute to Jim's comments as well because it's kind of related to one of 2 points that I wanted to bring up. The first point is that I had a MRI of the lumbar spine just last week and was diagnosed with spinal stenosis. So wasn't sure if anybody has yet experienced something like that. I've been told that that's not uncommon for seniors. I am 64 years old, but I have not yet spoken with my oncologist to determine if any of the medication I'm on has contributed to this diagnosis. My primary care doctor does say that I should start physical therapy, which I expect to do within the next week or two relating to that. So yes, I've also had muscle and joint pain, which led me to this MRI of the lumbar spine after I was initially diagnosed with a partial blood clot in my thigh, my left thigh, was put on a blood thinner. The pain was relieved, but because of the ongoing pain, that's where my primary care doctor recommended that I have this MRI of the lumbar spine. So that's.
I'd like to jump in. I have exactly what you've got. I just had an MRI last week. This is Jim from Maui, and osteoporosis, or the disc is degenerating in my lumbar L5, I think it was, and I think all my back pain started with the Nubeqa a couple months ago. It started getting better. I started Zytiga about a month ago, and that made it worse, way worse. And that's when I got my MRI. So I don't know, if it's the drugs we're taking that irritates. I went to the Dr. Fallett here, the radiation oncologist. She showed me the picture of my spine. The disc is actually pushing in on that spine. So when I stopped at Zytiga last week for 6 days, it got a lot better. I didn't have that pain in my back at all in the morning so much. So I don't know if it's the Zytiga that's making it worse. I'm kind of concerned about the osteoporosis because if my back gets worse, I can't even walk when it gets real bad. So that's what I was going to talk about anyway. I didn't know if it's Zytiga causing, the problem. And even my knee, which I had meniscus surgery done many, many years ago, when I started the Zytiga, that got worse. My knee got all of a sudden swollen up and bad, so that's a joint issue maybe there too. And when I started at Zytiga, my PSA jumped from 3.7 to 3.9. So I don't know what to do, So that's my 2 minutes there.
Right. I was on Zytiga for 6 months before it failed, and that was about 6 months ago. I've since was switched to the PARP inhibitor, olaparib, which has been extremely successful in making my PSA undetectable for the past several months. Part of the side effects, my oncologist did say, well, let's cut back a little bit on the PARP inhibitor, which we did for about 2 weeks. And I said, I'm feeling a lot better. And so he said, okay, well, let's try putting you back on the full dose, and I was more than willing to go back on the full dose because of the benefit of the PARP inhibitor that I've been experiencing. So I'm back on the full dose with that. So don't know if it's relating to that.
So, guys, I just wanted to say a couple of things about the osteoporosis. And Carl, do you know if have you done bone density tests? Are you?
Yes, I've done bone density tests and diagnosis osteopenia, which is I guess the step before osteoporosis.
Yep. So and one other thing, I guess that this comes to mind as well that I want to mention. So I was diagnosed osteoporotic when I started my hormone therapy, and even though I didn't have metastasis, I was placed on Zytiga, but annual doses. So I only ever got 3 annual doses, one at the beginning, one after the first year, and one after the second year. My back, when I started, my spine was minus 2.4, minus 2.5, which is right on the borderline of osteopenia, osteoporosis. And between the Zytiga and exercises that I incorporated, where I was specifically doing exercises, weight-bearing exercises on my spine, when I finished, I was at, I think it was -1 or minus 1.0. And it's pretty much stayed around that ever since. So I do think that whether it's the Zytiga or whether it's the exercise, you can make a difference. Now, the other comment I wanted to make is about the Zytiga. And some of you may know that there's been a conference in Basel this week to consider controversial issues in prostate cancer treatment. And one of the things they did talk about was the use of bone strengtheners. And Len will have to correct me here because I don't have time to pull it up and look at it. But I think it did say that any man who has advanced cancer and metastasis should definitely be on a bone strengthener. And there are a lot of docs that don't put you on that bone strengthener. And it is the protocol. So you have to ask for that. You have to ask for that for your doc to give you either Zytiga or Xgeva. It's really, I think it's an important addition to your treatment. And if it were me, again, I want to make this clear. I wanted to say this to Alexander. We cannot give medical advice. We can only talk within our own experience. We don't give medical advice. I can't say to you, you should be on this or you should be on that. I can tell you what I would do. And if it were me, if you guys have bone mets, I'd be getting a bone strengthener. We definitely think it makes a difference.
Right, and I have been on Xgeva. I think I've had at least 3 shots of it, and it's on a every 6-week cycle, which I understand could be done more frequently, but my oncologist was concerned about some potential side effects with the Xgeva, and that's why he's giving it to me every 6 weeks.
Right, so that's fine. I mean, personally, I don't think it makes a difference whether you get it 4 weeks, whether you get it 6 weeks. It's not an instant thing. It's a long-term thing that strengthens your bones. And the fact is that this stenosis has, come up over probably a long period of time. We don't know how much of it is related to the cancer. Now, it could be, because we know plenty of people that have had stenosis because they have METs identified in their spine. Do you have METs identified in your spine?
No.
Okay, so that's huge because the cancer loves to go to the spine, and what happens is it causes the spine to collapse, because when you get METs in your spine, they make the bone soft and they collapse. And, you know, some of you may remember Ray Swiderski, not Ray, but Debbie, who was regularly on this call and who now moderates our caregiver call. And when Ray was the day he was diagnosed with metastatic prostate cancer, his spine collapsed. He never got out of his wheelchair. And that's one of the reasons why those of you starting an LHRH, other than Firmagon, will be taking a buffer first, because they're very worried that it could cause spinal collapse if they don't know whether you have the spinal mets. So it is common, but if you're telling me you don't, then it's likely that the stenosis is not related to your cancer. Len has kindly posted in the chat window a link called which about treat your own back. Probably worth reading. Len, tell us about this article.
Yeah, it's not an article, it's a book. It's a very short book by a world-renowned physiologist named Robin McKenzie, called Treat Your Own Back. You can read the whole thing in like probably an hour, if not less. And I have degenerative disc disease. I've had it for decades, well before prostate cancer. And it involves stenosis of the spine. And it is age-related. It does tend to get worse as you age. So Treat Your Own Back is not going to reverse the degenerative disc process. However, it is designed to better align your spine and to strengthen the muscles that support your spine. So anybody who's got back pain of any, lower back pain of any kind, I do recommend that book. I've recommended it to 6 or 7 other people. They all come back and tell me that it worked wonders for them.
Thanks. And who else would like to come in on either fasting or back pain, back issues, or muscle issues, back issues? Guys, you're silent. Somebody must have some thoughts on this, or it's affected them.
I'd like to ask Carl about a lap rib, if you don't mind.
Yes, please go ahead.
This is Jay, Carl.
Right.
How did you get that approved? Did you have a difficult time getting it approved by your insurance?
It was approved for off-label use.
Okay. But they didn't give you a hard time. You just doctor had to say that he or she wanted to do it, and that was all it took, basically.
Right. The doctor had to write a letter justifying that I should be able to have access to it, although it's not yet FDA approved.
Okay. Thank you. My reason for asking is I just had a Foundation Medicine liquid biopsy, and they told me that a lap rib might work for me. A lap rib or several of the other PARP inhibitors. And I have yet to talk to my doctor about it, because I just started my Zytiga, and I'm hoping I get some life out of that. But if I don't, then a lap rib will probably be the next course of action. So thanks.
Okay.
So this is Peter. In the conversation, just listening to some of the guys and thinking about my own experience, I'm starting to have some serious concerns about Zytiga and possible muscle side effects. So that's going to be one of my big questions and pursuits this week down at the PCRI conference. See if I can take a survey and see if I can get some other guys and try to understand, whether more is going on than we know about in terms of muscle issues.
Mm-hmm. Well, and you'll report back to us, of course. And by the way, guys, anybody going to PCRI, please look out for Peter, and God willing, for Bill Franklin, as long as he doesn't get nailed by the hurricane. As he was going to join us last year, he got nailed by the hurricane, and he's worried this year, but we think we're going to get him there. Ken Mason, we're going to have a table, and we would love to see you. So is anybody on the call, on this call, planning on being at PCRI other than Peter?
Yeah, Jim, I am. I'm going. Okay. Peter's. Yes, Jim St. James.
Okay.
Sylvester plans to go, I know.
Sylvester plans to go. Carl, you're not going this year?
No, I'm not. There are 3 other conferences that are more closer to where I live that I'll be attending. One-day conferences.
Okay, great. Okay, well, we found Carl last year at PCRI. That's how he comes to the call. So, you know, hopefully we'll have a few new men from that. Okay, we can move on unless there's anybody else that has any questions. Somebody before wanted to get in and say something about back issues, I think.
That might have been me, Jim from Maui. Might have been that.
Okay. Anyone? So no one else?
I have a comment about bone strengthening. I know a lot of people like to think vitamin D, mega doses of vitamin D can help strengthen bones. But there was a recent study, and I posted it on our Facebook page, that said that 400, 5,000, and 10,000 milliunits or whatever they are of vitamin D actually decreased bone strength. So be careful. I know that's kind of like a fallback position for bone strengthening, and just be careful. You can find it on our Facebook page if you'd like to read the article.
Okay. All right, we're gonna move along here, and Dennis, you had a quick question for us.
Well, just a quick update. I just had my my 90-day blood work. Excuse me, and my Lupron injection, and everything. My PSA still holding at less than 0.1, and all my other blood parameters were within range. Nothing out of range. They did do a testosterone. I asked them, just kind of for the fun of it. I'm not looking to get testosterone back, but I'd kind of like to know where it is. It should be pretty darn low. But the report came back with it saying in process. So does it take longer to get the testosterone analysis?
Glenn?
Yeah, typically when I get my blood work done, testosterone and PSA don't come in till the following day after they've drawn the blood. Not sure why.
Okay. Yeah, I'll have to check. It's been like 2 weeks since my blood draw.
Oh, so there's a problem there. That's.
I think some of it might be, my local oncologist here is Dr. Raffia. They've started up, they're part of the new Arizona Blood and Cancer group that's been formed, which is part of a larger national organization, I believe. So they're kind of in new quarters, and new people working together. So I have a sense that some things might be falling between the cracks until I get fully established. But I did get like I said, all my other blood work, the PSA. But the report just said that free testosterone was still in process. So I got to follow up with them and see what's going on.
Yeah. Well, look, we are delighted, because here you are. How long have you been on Zytiga? A year and a half, 2 years?
Yeah, pretty close to that. Yep.
And so, it's working for you, and that is phenomenal. One thing that might be a good idea at some point, and maybe now isn't the point, but it could be, if it's appealing to you. I mean, you said earlier on, oh, I'll never be off these drugs. I'm a lifer. Well, you may be a good candidate for intermittent. You can try and see what happens. And, as soon, if it starts rising too quickly, you go back on. but don't rule it out. It's, you know, it's an alternative. Len, do you, or Peter, do you want to talk about, you know, what pushes you and what pushed you, and whether you give Dennis any tips on that?
Yeah, as long as you're comfortable, Dennis, with your testosterone level rising, you know, and if your PSA is remaining more or less stable, you'll have increased bone strength, increased muscle strength, and better cognitive function if you can find your way to intermittent therapy.
Yeah, I guess I understand it. But my condition at the moment, I'm tolerant of my situation. It's not causing me a great amount of stress. It's got obviously the side effects, which I think I've come to get used to them. And the fatigue issue is probably a big one. I get tired, but I take a nap and then I'm back and up and about. I recover from what I do have the bouts of fatigue fairly quickly. So it's generally, my Dr. Singh is pretty much said when we started here with the number of Mets I had and everything else, that this was probably, for the rest of my life to be on the Lupron. And, the Zytiga, like I said, it just did wonders for me when I started to have to rise again. The Zytiga is working as long as that's doing the job. And they did put the bone scans one by one side of each other on a split screen and showed me from my initial bone scan to where it is now. And, the Christmas tree, the lights have mostly gone out.
So, okay. We're just saying, anyone else want to say
Thank God for that.
Yeah.
Thank God for that. Whoa.
Yeah. Who is that? Who is that just talking? Who said thank God?
It's me, Jerry. My phone screwed up. I came back on.
Okay, Jerry. Okay.
Was that Dennis that was talking?
Yeah, that was Dennis.
Yes, it was.
Yeah.
Dennis, I certainly appreciate you giving that history because, as you know, I go to Dr. Singh also, and that's what he told me. I was going to be on Lupron for the rest of my life. Thank God right now I'm still resisting. I mean, I'm not castration resistant. The Zytiga and Lupron are working for me after 7 months now. So I'm still a newbie, but I have met from my sacrum to my neck. So
right.
I'm glad to hear it, Dennis.
Yeah,
thank you.
You said thank God, and I do thank God every evening and every morning when I awake.
God bless you.
I would like to put in a plug for the book that Professor Bill had talked about, the Book of Joy. It's really it's very inspirational, not specifically denominational or anything, but it's really easy reading. I'm not one that likes to sit down and read long books so it was really easy reading, and I would concur with recommending it for anybody that's got the disease that we have, where you're looking at a lifelong situation of dealing with it.
Excellent. Thank you so much. By the way, I spoke to Bill, I have to call him Thursday or Friday. He was doing great. I called him up. I called from London, Skyped him from London. I said, what you doing, Bill? Oh, I've been cleaning the house. I said, Bill, for Christ's sake, you couldn't even walk. Oh, I'm doing much better than 3 weeks ago, and I feel a lot better. And I mean, I was amazed. He was in the house on his own as well, which I wasn't thrilled about, but I don't have much to say on that. But having said that, it was really great to hear him doing as well. He feels good. He's he's getting up at 5 a.m. and he's writing. Fat, just to let you know, he's trying to finish some papers. So it's great. It's great. And I'll keep you updated, and we may hear his voice on these calls. Not sure. But anyway, we've got resources on IHT, I would say, Jerry, and Dennis. I mean, it sounds like Singh isn't a fan of IHT, but that doesn't mean you're not a candidate. And so, you know, you can always feel free to open the subject with him and go from there if you feel you need it. If you're happy where you are, you forget it, like Dennis, and we understand it. Jerry Pelfrey, you got to get your ass back down to Tucson so we can, the three of us can have lunch sometime soon.
Well, I'll tell you, I'm about ready to do that, but it won't be until probably December. But I'm strongly thinking of getting out of Prescott and getting back to my doctors in Tucson, and still keeping Singh, of course.
Well, we love to have you closer, and I may be passing through Prescott because I'm planning on driving up to see Len in Canab the week that he's there. So I'll look where I go, and you know, maybe we'll get a chance to meet. I'll give you a warning when I know my plans more.
Okay. We'd love that.
I'd love to meet you too. All right, let's keep going. I know it's 7 o'clock. We've got 2 or 3 people still to touch base with. Jim in Colorado, Joel Blanchette, and Paul Frieda. Let's go to Joel.
Yes, Rick, I want to just give you an update. Back on August 8th, 2019, I got a PSA that almost doubled on me, went from 0.4 to 0.7, and I was waiting to get above 0.5 so I could join the clinical trial that Len is on. And I called Yolanda, the head nurse there at NIH, and she says, have you had any surgeries in the last 2 years? I said, yeah, I had 2 new hips replaced. So, that may not be able to do a PET scan, a PET scan on that. So she said, let me ask the doctor. So she called me back a week later and says, yeah, the doctor says you're good to go. We'll probably be able to do you in October, November timeframe. I said, that's great. So I booked that, and based on your recommendation, Rick, I called Dr. Antonarakis at John Hopkins, and they gave me a list of things they wanted. So I drove it up to them a couple of days ago, and now they have it, and they've already scheduled me to see him on 1 October. And also, I'm going to see the VA in a couple of days, and I have an appointment with them, so see if I can get my Agent Orange payments brought up, since my cancer is biochemical failure, and maybe I can get more money. So anyway, as I'm getting a partial payment now. So that's basically my update.
That's all really good, and I mean, we like Antonarakis a lot. If you want to speak to Susan LaHaye, she has wonderful things to say about Antonarakis from her experience. So you know, that's a big positive, and I think we've had other guys that have seen him. Right now, you're not on hormone therapy, are you?
No, if I was, I wouldn't have qualified for the NIH clinical trial. That's one of the first questions she asked me. No, I've never been on radiation or hormone therapy or anything. I've just had a prostatectomy, and it's taken the PSA 7 3/4 years to get to 0.4, and now, but it just basically doubled on me. However, there's another issue involved here. My doctor switched PSA tests on me, a different lab or something. And so I got a note on my blood test report that said, you know, this PSA is probably 20% higher than it should be based on your other tests. So I'm sure you guys had some experience with that. I've never had that. So I don't know why she switched me, but I'll correct that next PSA.
Guys, who would like to say anything or something to Joel?
Joel, this is Len. Did you get a date for the NIH scan?
No, supposedly tomorrow, she's sending me a list of requirements that she wants from me, paperwork she wants from me, like she did with you, I guess. But I haven't received that. I expect it tomorrow via email, and then she'll give me a date. But she hasn't given me a date yet. She just said the October, November timeframe.
Okay. You're working with Yolanda?
Yolanda, yes.
Yeah. Keep after her. Sometimes she can forget about you.
Right. Okay. Good advice.
Yeah.
Okay. Anyone else have anything for Joel? Well, Joel, let us know how you do with Antonarakis, and if you would like to speak to Susan LaHaye, send me a note, and I will be very happy to connect you. It's very simple, and she is very, very supportive.
Okay, and she was a patient of his before?
Her husband was.
Oh, I see. Got it.
And she's one of our caregiver moderators, and she's great. She's a delight. She lives in Delaware, and she's terrific, and she'd be happy to talk to you. She felt their experience with Antonarakis was outstanding. So that's I'm happy to make that connection. You can give her a call if you'd like to. Just let me know. Okay. And whilst we're not happy that your PSA's gone from 0.4 to 0.7, I think that whatever the next stage of treatment is, my guess is it's going to have a very optimistic result.
It's going to have an optimistic result.
Yes.
Okay, great. Thank you.
Right. And Paul Frieda just left us. He couldn't stay any longer. I just noticed that. I'm sorry. I will send him a note and apologize. Or did he put a note? Did he put a note in the chat window here? I thought I saw something in the chat window. No, that was Jim Kubat. So let's go to Jim in Colorado. Jim, what's on your mind? Whoop. I guess we lost Jim from Colorado as well. Gonna have to send him a little note.
Well, at least we don't have to worry about recording.
He told us to leave him till the end, didn't he?
You did.
Yes, you did.
Okay, well, guys, so look at that. We're only 7 minutes over with two people bailing. What can you do? Len, anything you'd like to add?
Nothing from me, Rick. Thank you.
Jake, anything you'd like to add?
No, I'm good, thank you. I did put a link to that vitamin D study in the chat box if anybody's interested.
Okay, thank you so much.
Len, are you going to do SBRT?
Well, I'm going to see a radiation oncologist at Mount Sinai tomorrow, Peter, for a consult on whether or not I should do any radiation treatment.
Okay.
So next week I'll have some news, one way or another.
Good.
And I see Bruce. We kept calling on Bruce, and then Bruce appeared, and now he's left. I wanted to apologize to. Well, don't have to apologize. He was silently listening, so that's okay. Okay. Our next meeting will be next Tuesday, right? I don't have a calendar next to me like I usually do. Because I'm not at home. What day is it?
10th.
10th. So our next meeting will be the 10th, and that will be after PCRI. So we might get some interesting comments from Peter. And that's, I guess, a wrap. I'm trying to think if there's anything else. I don't think so. Alexander, delighted to have you on the call. I'm heading back down to Southern Arizona tomorrow morning. Oh, yes, I'm meeting Maureen. I'm meeting Dr. Steve's wife tomorrow morning for a coffee before I get on the plane. Great. So I'm really looking forward to that. You know, we lost Steve a year ago now. He died last August. So I'm very much looking forward to seeing Maureen before I get on the plane. But Alexander, otherwise, I would have run over to Fairfax. I did live in Fairfax for about 18 months. So I know Fairfax pretty well. So, okay. I will say goodnight, everybody, and talk to you soon. Peter, can you hold on? And because I want to talk to you about getting the banners to you.
Will do.
Okay.
All right. Well, good night.
Good night, everybody.
Good night. Thank you.
Good night.